Hi, my name is Rowena Han. I'm a fourth-year student at Toro, California. I'll be presenting on osteopathic considerations in a hospitalized patient with pneumonia. This encounter took place at the end of July on an inpatient medicine rotation. I didn't actually do OMT on this patient, but I wish I had, and that's going to be part of the presentation today. So to give some background on this patient, she's a 49-year-old female, past medical history of HIV, hypertension, asthma, chronic pain, and depression, presented to the ED with shortness of breath, chest pain that was pleuritic in nature. She was found to have a left-sided lobar pneumonia and sepsis. Her COVID tests were negative, and she was admitted for treatment of the pneumonia, sepsis, and fluid resuscitation. I've highlighted abnormal findings in her physical exam and her labs, which show that she meets CIRS criteria, has physical exam consistent with pneumonia. To give an overview of her treatment plan, we did start her on empiric antibiotics to treat community-acquired pneumonia, fluid resuscitated her. We didn't treat her hypertension, but we did treat her chronic conditions like her chronic pain, depression, and HIV. Over the first couple days, she didn't seem to be getting any better. Her white cell count went up, her O2 requirements went up as well, and so we added vancomycin. So my general rule of thumb when doing OMT in a hospitalized patient is the sicker patient, the shorter and more focused the treatment. And of course, goals of treatment, we think of ABCs, and then there's a few more here that are a little bit more relevant to a hospitalized patient. So starting with autonomics, T2 through 7 supplies parasympathetics to the lungs, and vagus nerve provides parasympathetics to the lungs. Biomechanics, what I think of when I have a patient with pneumonia is really optimizing respiration. One way you can do this is through ribs. Rib raising actually serves a dual purpose of not only improving rib motion, but also normalizing sympathetic tone. I could have also treated the diaphragm, various muscles of respiration, and also taken into consideration the bed positioning of the patient to make sure that it was at an angle where she could really breathe as best as possible with as little work as possible. When I think about circulation in someone with an infection, the first thing I think of is lymphatics. Really the role of the osteopathic practitioner is to get the lymph moving as much as possible. And of course, that would be starting at the thoracic inlet and moving peripherally. This patient had definitely had social considerations. She lived alone with a dog. Really soon after she was admitted to the hospital, she expressed concern about her dog who was home alone. And on day 3, when her medical condition was at its worst, she left the hospital AMA to check on her dog. And what I did as part of the treatment team was really try my best to set the patient up for success by communicating with the ED and the admitting night service to make sure that when she returned to the hospital, they would be briefed on her history and know exactly what to do in terms of treating her moving forward. And she actually did return to the hospital that evening and was able to continue her antibiotics and oxygen and recovered. NOCICEPTION is something that is a big issue for a lot of hospitalized patients, and in this patient, further complicated by the fact that she had a history of chronic pain for which she was taking Norco every 6 hours, had a high tolerance to pain, and the morphine that we were giving her wasn't really helping. And on top of that, opioids have the side effect of constipation, and OMT could definitely help with pain management and managing these side effects. And then, of course, always want to consider activity level, preventing complications like DVTs, and also in ICU patients, more serious complications like critical illness, myopathy, really important to ensure that the patient is mobilized. And I just wanted to end with this study by Knoll and al. In 2010, which really shows the benefits of OMT as an adjuvant treatment for patients with pneumonia. OMT decreases the length of stay, the duration of IV antibiotics, and decreases the incidence of respiratory failure and death compared to conventional care. So it's definitely a modality that I should have used when treating this patient and will use moving forward with my patients with pneumonia. And I just wanted to thank Dr. Pierce as well for a lecture on OMM for the hospitalized patient, which is really helpful in creating this case presentation. Thank you.